Welcome back to The Explainer, everyone. Today, we're unpacking a truly fascinating, yet honestly kind of overlooked, public health initiative. You know, when we think about healthcare challenges, our minds almost automatically jump to remote rural villages, right? But what about massive, rapidly expanding cities? Urban growth has led to this huge surge in the urban poor population, with so many folks living in slums and squatter settlements. And here's why this matters to every single one of us. Public health in a city affects the entire urban ecosystem. I mean, disease doesn't exactly respect neighborhood boundaries. So, to understand how this hidden health crisis is being tackled, we are going deep into the National Urban Health Mission, or the NUHM. We're going to look at the policies, the people, and the amazingly structured system designed to bring healthcare literally directly to the doorsteps of those who need it most. Here is our roadmap for this explainer. We're going to move logically from a massive macro-level problem all the way down to a micro-level community hero. We'll cover the urban health paradox, introduce the NUH, look at the delivery model, meet the USHA, and finally wrap up with services and incentives. Okay, let's dive right into this with Section 1, the urban health paradox. Proximity does not equal access. To really grasp why the NUHM was even created, you have to consider this massive paradox. Just living near a huge modern city hospital doesn't actually mean you can get care. The urban poor are constantly experiencing this crowded out effect, where ineffective outreach and weak referral systems completely block them from the system. Just look at these numbers. The general urban average for the under 5 mortality rate sits at 51.9, but for the urban poor, it spikes dramatically up to 72.7. Proximity to state-of-the-art medical facilities means absolutely zero if the system isn't designed to actually reach the marginalized populations living right down the street. And the gaps in preventative care, they are just as startling. According to the NFHS3 statistic, almost 60% of urban poor children miss total immunization before completing their first year. Let that sink in for a second. 60%! When you combine that lack of baseline preventative care with the incredibly tough environmental conditions in slums, we're talking high population density, inadequate sanitation, unsafe drinking water, these communities become highly vulnerable. Asthma, tuberculosis, and vector-borne illnesses like malaria just spread like wildfire. In fact, the urban poor suffer from twice the incidence of malaria compared to other urbanites. This isn't just a slight disadvantage, you guys. It's a structural crisis requiring a highly specific intervention. That brings us to Section 2, introducing the NUHM, a targeted solution. The government's direct response to this hidden crisis was the NUHM. And what's brilliant is that it doesn't just treat the city as one big homogeneous block. Instead, it recognizes that to fix the paradox we just discussed, you have to be laser-focused. Urban planning is incredibly complex because the population is so diverse. So the NUHM places a high focus on very specific vulnerable populations. We're talking about the homeless, street children, rag pickers, rickshaw pullers, construction workers, sex workers, and temporary migrants. Traditional static clinics really struggle to serve these groups because they're transient, marginalized, and totally outside the formal employment sector. The whole point of the NUHM is to facilitate equitable access and strengthen public health capacity specifically for them. Moving right along to Section 3, the delivery model, from national to city level. Now, what's really interesting here is how this massive bureaucracy actually operates. The institutional framework of the NUHM is perfectly designed to leverage existing structures, but totally modifies them for urban needs. At the very top, the national level, you've got the mission steering group under the Union Health Minister, supported by a coordination committee. But you know, policy can't just live in Capitol buildings, right? It trickles down to the state level, managed by the State Health Society. And then, crucially, it hits the city level. This is where states can constitute a city urban health society to manage operations directly on the ground. This structural flow demystifies the whole process. It ensures that funding and broad strategies don't get lost in dry bureaucracy, but are actually executed by local urban bodies who truly understand the layout of their own city slums. Okay, let's pivot to Section 4. Meet the USHA, the community link. This is where we go from that top-down macro structure to the human-centric micro level. It's time to meet the true core hero of this entire system, the USH. USH stands for Urban Social Health Activist. While the urban delivery model relies on organizing existing public health care, its true absolute power comes from community participation. The USH is that frontline community worker. She is the crucial demand-generating link between the formal healthcare system and the designated slum area she's in charge of. Literally, without her, that intricate delivery model we just looked at would completely stall out before reaching the actual people who need it. To really understand how deeply embedded she is, just look at the specific scale of a single Yusha's responsibility. Each community is assigned one Yusha for roughly every 1,000 to 2,500 beneficiaries. To put that into perspective, that's about 200 to 500 households. This spatial consideration is absolutely vital. It means she isn't stretched so thin that she becomes ineffective. She actually knows the families. She knows which households have pregnant mothers, which have unvaccinated infants, who might have a communicable disease, and she's ideally co-located at a local Anganwadi center, making her a highly visible, incredibly accessible fixture right there in the neighborhood. Now, you can't just parachute a total stranger into a vulnerable community and expect instant trust, right? The policy completely transforms into a relatable, human job description here. The selection criteria are super specific. First off, she must be a female resident of the exact same area. She needs to be a familiar face. She should preferably be between 25 and 45 years old with formal education up to Class 8. Though actually, that education requirement can be relaxed if needed, because community trust heavily outweighs a piece of paper. And finally, she isn't just appointed by some distant manager. She is chosen through a rigorous consultative process involving community groups, self-help groups, and local NGOs. She is essentially chosen by the people she serves. Let's move to our final part, Section 5, and see how this builds services and incentives, empowering the frontline. The daily workload of an USHA is extensive. It is entirely focused on bringing preventative and primary care directly to the doorstep. She actively promotes good health practices regarding nutrition, sanitation, and hygiene. Remember that 60% missed immunization rate we talked about? She directly combats that by providing crucial counseling on immunizations and safe delivery. She motivates the adoption of contraception. Very practically, she acts as a local depot holder for essential supplies, things like oral rehydration therapy, iron folic acid tablets, and condoms. Plus, she maintains vital records, logging births, deaths, and tracking immunizations. She's essentially a health educator, a supply distributor, and a record keeper, all rolled into one incredible role. So how does the system sustain all of this hard work? Well, let's break down the abstract concept of incentives into cold, hard numbers. The USHO operates on a performance-based incentive structure. For instance, organizing an outreach session earns her 200 rupees. Organizing a monthly meeting of the Mahila Arogya Samiti, which is a local women's health committee, gets her 100 rupees. Attending the monthly meeting at the primary urban health center, that's another 200. And for the really painstaking work of conducting a baseline survey and maintaining the family health register, she gets 5 rupees per household. This piece rate system ensures that proactive preventative health measures are directly rewarded. It perfectly aligns her livelihood with her community's health outcomes. And this brilliantly illustrates the entire philosophy of the National Urban Health Mission. The policy itself states, the USHA would actually be the nerve centers for delivering outreach services in the vicinity of the doorsteps of the beneficiaries. They literally are the central point. All information, all resources, all care radiates outward from them into the dense, complex web of the urban slums. Without this nerve center, the whole institutional model would just remain totally disconnected from human reality. Which brings us to a final thought to ponder today. We've seen the staggering paradox of urban health inequality, and we've walked through the NUHM's highly structured, targeted response. But at the very core of this massive national bureaucracy is a remarkably simple, profound strategy: hiring and training a local woman to care for her own neighbors. It really forces us to ask, is empowering local, trusted women at the grassroots level the ultimate key to bridging this massive urban healthcare divide? It's such a powerful model of community-led public health that really challenges how we think about medical delivery systems altogether. Thank you so much for joining me on this deep dive into the NUHM. Keep learning, keep analyzing, and I'll see you on the next explainer.